Okay. So cardiothoracic surgery, now we are going to discuss. See, cardiothoracic is a topic which is covering the disease inside the mediastinum, surgical disease inside the mediastinum. So mediastinum is of 4 types: superior mediastinum, anterior mediastinum, middle mediastinum, and posterior mediastinum. See, don't forget the most common mediastinal mass is thymoma from Bailey and Love. Most common mediastinal mass is thymoma. Thymoma is the most common mediastinal mass. So anterior mediastinum, there is a thymoma seen, and lymphoma, germ cell tumors are all common, and thymoma is most common in anterior mediastinum. It's common in anterior mediastinum. And posterior mediastinum, the most common tumor is neurogenic tumor. Don't forget these two. So posterior mediastinum is behind the heart. The common tumor seen here is neurogenic tumors. Thymoma is seen in anterior mediastinum. In all these mediastinums, you can get lymphoma. You can see from the table. All the places you can get lymphomas. Superior mediastinum, you can get retrosternal thyroid, retrosternal goiter. Retrosternal goiter is present in superior mediastinum. Don't forget this. So let us now discuss about thymoma. Thymoma is the most common location is anterior mediastinum. It's most common in old age, above 60 years. Usually above 60 years, these thymomas are seen. Usually they are asymptomatic masses. Many of them will not come because of this mass, and these patients will be usually asymptomatic. Usually this is asymptomatic, not symptomatic. It is usually asymptomatic. There is no gap. Incidentally detected on an X-ray chest as a widened mediastinum. So if at all, if it is very big, they can come to you with the dyspnea or SVC obstruction. When superior vena cava gets obstructed, you can see dilated veins in the face. All those things can happen occasionally. There is a very interesting point called as paraneoplastic syndrome. What is the most common paraneoplastic syndrome? Yes, what is the most common paraneoplastic syndrome? Can you tell me? Yes, the most common paraneoplastic syndrome is myasthenia gravis. Don't forget that. Myasthenia gravis is one of the important thing you should not forget. Myasthenia gravis. See, they used to mention in books, especially Bailey and Love is mentioning, even if a patient is not having myasthenia gravis, when you remove the thymoma, myasthenia gravis gets recovered. This is a line, interesting line from Bailey and Love. Even if patients are not having myasthenia gravis, just remove the thymus gland, they will be all right. This is a line from Bailey and Love. So myasthenia gravis disappears after resection of thymoma. What is the staging used? Chang staging used in medulloblastoma. Please don't forget Chang staging used in medulloblastoma. What is this staging here used? This is a repeat MCQ, very old MCQs. Very good, Sushma. Masoka staging system. See, you can find out whether it is a benign or malignant thymoma only after removing because of the capsular invasion. When the capsule invasion is present, it is malignancy. So treatment is by sternotomy and excision. We have to do sternotomy and excise the tumor. So there are new methods of treatment like VATS and RATS. VATS is video assisted thoracoscopic surgery. We can remove it by video assisted thoracoscopic surgery. By video assisted, you can remove, or by means of robot assisted thoracoscopic surgery. You can either remove it by video assisted or robot assisted thoracoscopic surgery, or the new updates of this cardiothoracic surgery. So cardiothoracic surgery can be now done by video assisted or by robot assisted. So thymoma, don't forget myasthenia gravis and Masoka staging system. It's very common in old age. And another important topic from cardiothoracic surgery will be on coronary artery bypass grafting. So I want you to know, from the root of aorta, there are 2 important vessels which are going to supply the myocardium. So don't forget, there are 2 important vessels which are going to supply the myocardium. One is left coronary artery and another is a right coronary artery. So I'm not going into the fine anatomical details from which route it arises and all, but just remember right coronary artery and left coronary artery. And the most important artery is left coronary artery is going to give a branch called as left anterior descending artery, and this is circumflex artery. This is circumflex artery. So left anterior descending artery and circumflex artery are the two branches from left coronary artery. So now this is called as triple vessel disease. When you would have heard about triple vessel disease, when there is a thrombosis of the right coronary artery, left anterior descending or circumflex, we call it as triple vessel. These are the three vessels supplying the myocardium of the heart. Muscle of the heart is supplied by three vessels. What is myocardial infarction? When the coronary arteries, which is supplying the heart, gets blocked, it is called as myocardial infarction. The heart muscles gets gangrene, ischemia. So this is triple vessel disease. Main vessel disease is if the left coronary artery obstructed, it is called as major vessel disease. So you would have heard about like this when a patient talking to a patient with a heart attack, they will tell, sir, I had a major vessel disease, I had a triple vessel disease, I had a two vessel disease, I had a three vessel stented, two vessels, like that they will be telling to you. So the major role of cardiothoracic surgeons is to do bypasses of the thrombosed vessels. So nowadays the bypass numbers has come down because of the stenting. We can easily put a stent into the left coronary artery, right coronary artery, or any artery you can put a stent. Therefore, the bypass grafting is one of the important topics you should know from cardiothoracic surgery. The commonly used vessels are long saphenous vein and Lima, left internal mammary artery, because you are going to do sternotomy and operate. At that time, internal mammary artery will be running inside. You can take and use for graft. So long saphenous vein is the most commonly used vein. Okay, long saphenous vein is the most commonly used vein. 10 years patency is 60%. For left anterior descending artery, please remember, left anterior descending artery and left coronary artery, we cannot use veins. For these two, we have to use Lima, because arteries have a 10 years patency is around 90%. That is why for major vessels like left anterior descending and left coronary artery, you should only use arteries, don't use veins. So if artery Lima is not available, you can use Rima, right internal mammary artery, or radial artery also can be taken. If Lima is not available, use Rima or radial artery. If long saphenous vein has been removed for some reasons, you can use short saphenous vein or cephalic vein can be used. So bypass grafting is done for left anterior descending and left coronary artery are important vessels. Please don't forget. These two I should do bypass from which artery? Bypass from left subclavian artery to these vessels by using. So you do a bypass. See, this is a picture of left subclavian artery going here. So from the left subclavian artery, we do the bypass like this, like this. So from left subclavian artery, we bring a bypass because the aortic route is not good, no? So we'll bring it from there and do this. So bypass from left subclavian artery using Lima. See, bypass is one of the famous surgeries once upon a time. Now, with the invention of stenting, many bypass surgeries has come down. But even now, there is a role of bypass grafting due to triple vessel disease, major occlusion where you cannot put a stent and all, people going for bypass. This is an image showing you from a left subclavian artery, you can see we are using Lima to left anterior descending artery. This patient is having a thrombosis here. Therefore, we have done a graft. Similarly, for a circumflex artery, there is used a vein. So vein graft is used from aorta. Aorta, we can bring a vessel like this. From aorta, you can use like this. Don't forget this. Another important role of cardiothoracic surgeons is to use mechanical valve replacement for mitral stenosis, mitral regurgitation, pulmonary stenosis, pulmonary regurgitation, tricuspid stenosis, tricuspid regurgitation, aortic stenosis, aortic regurgitation. In all these patients, either it can be a rheumatic valvular disease or acquired valvular disease following an MI. So following a myocardial infarction, the valves can get damaged. So any valve which is so much damaged, causing a lot of medical problems, you would have read about aortic regurgitation and all. In such cases, you can keep mechanical valves. Mechanical valves are available in any age group. In many sizes, it is available. Mechanical valves are available in many sizes. Biological valve is usually taken from three types. Autograft from the same patient. For example, mitral valve is more important than a tricuspid valve, than a pulmonary valve. You can cut the pulmonary valve and you can use it in the mitral valve place. That is called as same patient. Allograft from a cadaver. We have already discussed. From a cadaver, you can take graft, or you can use xenograft from the pigs. So the main advantage of biological graft is it is very soft graft. So no need of any anticoagulation because it is not going to rupture the RBC. Whereas mechanical valve ruptures the RBC and releases coagulative substances. Releases coagulation factors. It ruptures RBC and releases coagulation factors. Therefore, anticoagulation is needed lifelong. That is a major disadvantage of mechanical valve. Mechanical valve, the advantages, one important advantage is mechanical valve has long patency. So advantage of mechanical valve is when you do a mechanical valve, it is having more than 15 years to 20 years patency. Whereas biological valve, if you see, life expectancy will be only 8 years or less. In 8 years, the valve will get thrombosed. Okay. Yes, because of the ruptured RBC, you will see a lot of peripheral smear findings. Like a hemolytic anemia like pictures will be there. So don't forget, less life expectancy following a biological valve, whereas when a mechanical valve, more than 15 to 20 years patency will be there. So this is a picture of a mechanical valve, this is a picture of biological valve. So most common complication of using a valve is thrombus. Thrombus formation is most common in mitral valve. So it's mitral valve. It is most common in mitral valve. Same line. It is most common in mitral valve and it is most common in mechanical valves than biological valves. So the another problem is the valves can leak and the prosthetic valves can go for endocarditis. The most common organism is staph epidermidis. So the most common organism which can happen in the valve endocarditis is staph epidermidis and the mortality is around 20% in these patients. Prosthetic valve endocarditis can cause a mortality of 20%. So please don't forget the mechanical and biological valves. And the next interesting topic which is asked very commonly in surgery as well as in medicine is on bronchogenic cancer. It's the most common tumor inside the mediastinum. Most common primary malignant tumor. Malignant tumor of mediastinum is bronchogenic cancer. It is commonly seen in the lung hilum. It is a visceral cancer. It is a common cause of cancer due to death. There are two categories. Small cell cancer and non-small cell cancer includes adeno cancer, squamous cell cancer, and large cell cancer. Small cell cancer is also called as Wyatt cell cancer, also called as neuroendocrine tumor. It's also a neuroendocrine tumor. Metastasis risk is highest with a small cell cancer. Metastasis risk is low metastatic potential. Worst prognosis, small cell cancer is worst prognosis. Non-small cell cancer is good prognosis. Response to chemotherapy is good with small cell cancer. Response to chemotherapy is very bad with non-small cell cancers. Since small cell cancer is a neuroendocrine tumor, it produces a lot of paraneoplastic syndromes like Cushing, Eaton-Lamberton syndrome, Cushing syndrome. So Eaton-Lamberton is like a myasthenic gravis. It's like a myasthenic-like syndrome. And they also produce SIADH, syndrome of inappropriate antidiuretic hormone syndrome. So a lot of paraneoplastic syndromes are produced like Cushing syndrome, Eaton-Lamberton syndrome, SIADH syndrome. All these are seen with small cell cancers. Non-small cell cancers, paraneoplastic syndromes are very rare. There are few features we'll discuss, but usually it is rare. So centrally located, small cell cancers are centrally located in the lung. Non-small cell cancers are peripherally located in the lung. So what is this centrally peripherally means? You should understand, if this is the lungs, if the tumor is located in this place, it is central. So it needs full removal of lung. Peripheral is like this. It is better. Peripheral located is easy to remove. This is peripherally located. Centrally located are usually small cell cancers. So therefore, what are the clinical features of lung cancer? Usually lung cancers are seen on right upper lobe. The most common presentation is cough. Please don't forget, cough is the commonest presentation. Dyspnea can be due to pleural effusion or due to atelectasis of the lungs. Sudden atelectasis of the lungs or pleural effusion, they get dyspnea. Hemoptysis is usually less common. Many people might think hemoptysis is a common symptom, but it is less than 50%. It is a bleeding source from bronchial artery. Don't forget, it is a bleeding sources from bronchial artery. There may be hoarseness of voice, that is recurrent laryngeal nerve palsy. Due to recurrent laryngeal nerve palsy, there may be hoarseness of voice. Superior vena cava can get obstructed, causing dilated veins in the neck and congestion of the face. Eaton-Lamberton syndrome is a muscle weakness. Very commonly asked MCQ is Pankhurst tumor, a tumor in the apex of the lung like this. Especially, it's a squamous cell cancer. Please don't forget, this is a common MCQ. Pankhurst tumor is a squamous cell cancer in apex of lungs. Compresses. It is compressing the sympathetic chain. C8T1 compression results in a syndrome called as, what is it? The image-based question, Horner's syndrome. Horner's syndrome characterized by ptosis, meiosis, and hydrosis. So ptosis, meiosis, and hydrosis are the three features of Horner's syndrome. You can see the classical finding of ptosis, meiosis, and hydrosis. Due to the constricted pupil, you are seeing that there is a ptosis, meiosis, and hydrosis in these patients. This is a classical finding of squamous cell cancer in the apex of the lungs. So squamous cell cancer, they may have Horner's syndrome plus erosion of first rib. There will be erosion of first ribs will also be seen in this Horner's syndrome. So don't forget Horner's syndrome. So now the very important point to differentiate is squamous cell cancer and adenocancer. Most common cancer worldwide is adenocancer. Most common cancer worldwide is adenocancer. In India, it is squamous cell cancer. Most common among non-smokers is adenocancer. Most common among females is adenocancer. Adenocancer is peripherally located. But squamous cell cancer can be located central region. I told you small cell cancer and squamous cell cancer both are centrally located. It's only adenocancer, very important. You should not forget peripherally located. I told you these non-small cell cancers, the paraneoplastic syndromes are very rare. But squamous cell cancer can produce ectopic ACTH and can cause hypercalcemia. This is a very commonly asked MCQ. So what is the most common paraneoplastic syndrome in squamous cell cancer? It is causing hypercalcemia of malignancy. Hypercalcemia of malignancy commonly from squamous cell cancer. Hypertrophic pulmonary osteoarthropathy, migratory thrombophlebitis, DIC, all are seen in adenocancer. So best prognosis is squamous cell. Good prognosis is adenocancer. There is another rare cancer I told you. Large cell cancer produces galactoria in females and gynecomastia in males as a paraneoplastic syndrome. Large cell cancer. See, small cell cancer is a bad cancer. It can produce extensive metastasis. Anywhere it can produce metastasis. Please remember, metastasis is commonly seen to brain, liver, adrenal, all places you can see metastasis. Brain, liver, adrenal, everywhere metastasis will go from small cell cancer. Brain, liver, adrenal metastasis are common in small cell cancer, whereas all these cancers, squamous, adeno, large cell, all have less risk of metastasis. Don't forget that. So non-invasive investigations and invasive investigations for lung cancer, don't forget chest X-ray, CT thorax is the first investigation to be done. If you suspect lung cancer, PET-CT is useful. Sputum cytology is also useful. So invasive investigations are bronchoscopy, endobronchial ultrasound and biopsy, CT guided biopsy. All these are invasive. So you have to do a bronchoscopy because it is a bronchogenic cancer. You should put a bronchoscopy and take a biopsy. Or endobronchial ultrasound guided biopsy or a CT guided biopsy for a peripherally located tumor. Very interesting point. If the tumor is peripherally located, you cannot do a bronchoscopic biopsy. You should take for a CT guided biopsy. Centrally located means you can take bronchoscopic biopsy. Sometimes we can even go for VATS, put a video assisted thoracoscopy and take biopsy from the nodes. You can go through the suprasternal region, mediastinoscopy. These are all invasive investigations. All these are invasive investigations. And once you confirm the malignancy, the treatment is straightforward. Please remember. So you know very well, there are multiple segments, like 10 segments are there in the right lobe. And I'm not going into the detailed anatomy of the segments. You have segments like this. There are 10 segments and 3 lobes on the right side. 10 segments and 3 lobes on the right side. So if there is a cancer on each small segment, for a small segment is having a cancer, I can remove only that segment. That is called as segmentectomy or wedge resection. If there is a tumor involving one lobe, you can remove. Upper, middle, lower lobe, you can remove that lobe. So can be performed by a VATS or thoracotomy. You can do a lobectomy, segmentectomy, lobectomy. Centrally located tumor may need pneumonectomy, removal of full lung. Full lung should be removed. So when removing the whole lung has a highest mortality, we have to clamp the bronchus and remove this entire lung, ligating the major vessels like main pulmonary artery, superior and inferior pulmonary veins, and main bronchus are divided without stump. Don't leave any stump. Go and cut at the level of bifurcation level. You have to go and cut this stump. So that is pneumonectomy. So 3 surgeries are done: segmentectomy, lobectomy, pneumonectomy for lung cancers. So the 2 surgeries done for thoracics by thoracic surgeons are opening the thorax and going inside. Elective cases, we put the patient whichever side problem. For example, I'm having a right side problem. Put me in left lateral position as shown here. So correct positioning of thoracotomy for a problem in this side lung or somewhere on the right side. So this is called as posterolateral thoracotomy. So put the patient in a lateral position with a pillow in between the limbs, and between the 2 feet, you have to keep a pillow, and you can open at level below the angle of scapula. So incision done below the level of angle of scapula, you make a long incision, open the ribs and put a retractor and go inside and operate. So the question which is expected here is, what is the order of muscles cut in a posterolateral thoracotomy? That is the reason I put here A, latissimus dorsi, first muscle. B, second muscle is serratus anterior. Third muscle is intercostal muscle, C. So intercostal muscle. So latissimus dorsi is divided in line with the skin incision from Balian lobe. Is divided in incision along the skin incision. Along with the skin incision, you can cut the latissimus dorsi. If serratus anterior is divided, it should be close to the attachment of the ribs. Attachment to the ribs of 6, 7, 8, you have to cut. Intercostal muscles are stripped always from the upper border of the rib. You should not go towards the lower border of the rib. I hope you know the reason, because if this is a rib, the lower border of the rib has intercostal artery and intercostal vein. So you always should cut at the upper border. L, S, I. That is the order of cutting of the muscles. L, SI. In a posterolateral thoracotomy, the order of cutting of muscles is LSI. So latissimus dorsi, serratus anterior, and intercostal muscles. So there is, in an elective case, I can do all this positioning and all. But in an emergency, patient is in a trauma, patient is having extensive bleeding from the thorax. In such case, I cannot make the position change and all, because some surgeon will be doing laparotomy and I need to go for thoracotomy. In such cases, I go for a left anterior thoracotomy, especially for a patient who are having pericardial tamponade. Please remember, pericardial tamponade. Now the answer is no more pericardiocentesis. Directly shift them to OT. Open the left anterior thorax. Incision is done at the level of 5th intercostal space. Just open the ribs and go inside. This is left anterior thoracotomy, is done for emergency situations. So elective cases, you can do posterolateral thoracotomy. Either it can be right or left according to the pathology. In an emergency cases, always it is left anterior thoracotomy to reach the heart. Because the patient is having a bleeding from the heart or from the aorta, there is a problem from the aorta. In all these cases, you need to go for a left anterior thoracotomy. And most of you might have heard about another thoracotomy called as clamshell thoracotomy, though it is not from Bailey and Lowe. What is clamshell thoracotomy? See, for example, I have done a left anterior thoracotomy like this. Sometimes the pathology is not found on the left side and it is on the right side. In such case, you extend the incision to the opposite side like this and you raise the chest like this. You lift the ribs like this. That is called as clamshell, because it is a bilateral anterior thoracotomy. Bilateral anterior thoracotomy is called as clamshell. Because I thought it will be a problem on the left side and I opened, but the problem went on the right side also. So I have to lift it on both sides and do the surgery. This is called as clamshell thoracotomy. Clamshell thoracotomy. So please don't forget, this is a very simple chapter. Very few questions have come from the bypass, from the bronchogenic cancers. Few questions have come. That's all. So which cancer causes superior vena cava obstruction? Is superior vena cava obstruction is most common with small cell cancer. Pancreas tumor is most common in squamous cell cancer. So Eaton-Lamberton syndrome is most common in small cell cancer. Like that, some few basic questions only will come in this topic. Just remember this basics of cardiothoracic surgery.